Good evening. I'm Dr. Constance Bonnet, and today I will be presenting dehydration in the older adult. The goals of this presentation is to provide an overview of dehydration, to discuss risk factors associated with dehydration in the older adult, and discuss evidence-based treatment modalities for dehydration. Continuation of the goals for this presentation is to provide the utilization of free teaching strategies. The first one that will be used today is to lecture, accompanied by a PowerPoint presentation. Second will be problem-based learning, which is a discussion of scenarios, followed by a debating between the students for the pros and cons of a specific solution to problems. The objectives of this presentation: students will acquire new knowledge of dehydration in older adults. Students will be able to define dehydration. Students will be able to identify 4 risk factors of dehydration. Students will be able to recall treatment protocols of dehydration in the older adult. And students will take new concepts of dehydration in older adults and apply it to clinical situations. Dehydration in older adults. An older adult is considered anyone greater than or equal to 65 years of age. So dehydration basically is a water loss. There's a decrease in water intake. Serum osmolarity level is usually greater than 300. Also followed by sodium concentration, which is increased, greater than 150. So you want to look for those lab values, and that is indicative of dehydration in older adults. Shift of fluids. Fluid leaves the intravascular and goes intracellular, therefore causing a shrinkage in the cells. Also in the older adult, there is a minimum regulation of hydration, hemostasis. You see smaller fluid reserve, decrease in the body, total body of water, decrease in the thirst response, or a decrease in appetite, decreased concentration of urine and poor kidney function. Also, you see a decrease in the muscle mass. Statistics: 20 to 30% of older adults experience dehydration. It accounts for over 300,000 admissions into the hospital, in which 50% are usually older adults. And it costs the healthcare system over $2 billion a year. It is associated with longer hospital stays. It also increases mortality of patients. Let's look at some risk factors in the older adults. And remember, that's anyone considered greater than or equal to 65 years of age. So let's look at the health factors. Cognitive impairment, that can include syncope, delirium, dementia, Alzheimer's disease, and not limited to those disease processes. Also chronic disease complications, CVA, congestive heart failure, acute renal failure, chronic renal failure, dialysis patients. You want to look at increased frailty, adverse drug effects. Remember, a lot of time patients are on medication for heart failure. You may see Lasix given daily, which can lead to further dehydration if you don't have adequate hydration management. You want to look at reduced bladder control, incontinence. How are we measuring intake and output? Are these patients being adequately hydrated? So let's look at some social factors. Isolation for the older adult, community dwelling adults, availability or accessibility to food or drink. If I'm frail and cannot get out of bed, I can't get up and get my drink. So that can lead to dehydration. Complication of dehydration: falls, they're prone to infection, renal failure, drug toxicity, bowel obstruction because you don't have enough fluid to increase peristalsis, and then the stool becomes hard. Hypothermia, which is an increase in the body's temperature. Cardiovascular complications. You see palpitation and persistent tachycardia. Also, final result can be death if untreated. So when we talk about assessment, these are some of the things that we're looking for that's indicative of dehydration. Weakness, dry mouth, swollen tongue, increase in thirst, but remember in the older adults, you might not see that because they have the decrease in the homeostasis. Dizziness, headache, palpitation, tachycardia, some confusion, possibly fainting or syncope. But the one thing that I left last is the sternal skin turgor. In older adults, it's best to do a sternal assessment. So with that being said, you want to look at the sternum, maybe midline to the nipple, and you want to pinch it, but gently, not to cause bruising. And if that skin stays elevated, that's indicative of dehydration in the older adult. Barriers to adequate oral hydration. Some caregiver considerations. Poor staffing for a facility. If the patient is living in a long-term care facility or residential, often there's not enough staffing to provide the patient with one-on-one care that would assure that their hydration status is being met. Poor communication skills with residents or patients. Again, staffing shortage, or the patient cannot speak or has had some type of impediment, such as a stroke, and has poor speech or not understandable. Let's look at insufficient oral intake. All this can lead to insufficient oral intake. And some patient considerations. Absence of thirst. Again, in an older adult, you don't see where they have the need or doesn't have that stimulation to have that, say, oh, I need a cup of water or something. Physical limitations. Patient does not have preferred drink of choice. So oftentimes, it's just generic drinks that are available. Treatment for dehydration in an older adult. Hydration management. According to the Institute of Medicine, for the active older adult, it's 3.7 liters of fluid per day. And in the older female, it's 2.2 liters of fluids per day, okay? And some interventions that may be helpful is the placing of the cooler or the water dispenser visible, where you can see that there's water available and it might stimulate, oh, I want something to drink. Also, the usage of a bright colored water pitcher, such as red or orange. As we get older, we lose our vision, and sometimes seeing the bright water cooler can stimulate, I need to get something to drink. Incorporate frequent bathroom breaks or bladder training management of incontinence. Often we have to monitor intake and output of patients, and if they're not getting enough to drink, well, we won't have any fluid in the diapers. Incontinent brief. Daily intake and output logs. Also provide drinks during social period of dining. Often, older residents or in residential homes, the residents come to the dining room to eat. So you want to also provide adequate water or a different type of beverage for them to drink. Some nursing goals for hydration management. You always want to assess your patient and provide all the health care that they need. You want to screen for risk factors, and one big thing is dysphagia. Often patients sometimes have strokes and cannot swallow adequately. And as we get older, we lose some of our function. So you always want to monitor that for dysphagia, because it can lead to aspiration, pneumonia, and also choking episodes. Again, you want to monitor labs. Serum osmolarity level greater than 300, indicative of dehydration in the older adult. Also, sodium level, that's 150 or greater, is indicative of dehydration in the older adult. You want to collaborate with healthcare team members. You want to provide this interprofessional relationship with all members of the healthcare team in order to provide the best patient care for this patient. You want to provide a variety of choices to the patient again, and assist the patient whenever necessary. We have just discussed dehydration in the older adult, and we will go over some questions. First case that we will be looking at today, we have a 70-year-old patient who presented to the emergency room today at 2 o'clock by ambulance. Patient presented with dry, cracked tongue. Pulse rate, I want you guys to refer to the EKG strip to the left. He had a dry incontinent brief on and a sodium level of 152. So based on this scenario, I want you guys to determine if it's tachycardia or not tachycardia with dehydration or not dehydration, and what other tests should be considered, and what education should be provided to the patient and caregiver. I want you to divide into separate groups of 4 to 5, and I will allow 15 minutes for the discussion of the scenario, and then we will come back to discuss it. So the first case study and scenario that we looked at, you guys did a really well job on. So let's go to the second question. We have another patient who presented, and that patient is in room 322. So I'm going to give you guys time to read over this scenario, and this time I want you guys to participate in different groups so we can have a different perspective. So now we will be having something pretty much that I think will be very entertaining for you guys. We will be debating different scenarios and topics on dehydration and possibly other diagnoses. So you guys will break up into 3 separate groups, and the first panel, which will be the first group, will have an opportunity to tell us the diagnosis of the scenario patient case, followed by the second panel discussing it and agreeing or not agreeing with the diagnosis and giving me rationales to why it's not or why it is. And then the third panel, again, will disagree or not disagree. So we'll keep it going. And this should take pretty much until the end of the class period. Students, you all did a wonderful job today. Could I get any feedback on to what you thought about the debate today?
So the debating process was really fun, and I got to learn something new and interesting, but in a fun way, where I got to collaborate with my peers and learn something new.
Sounds very good. Well, thank you so much, students. And this concludes the presentation today. These are the references for you if you need to further look up any information.